I'm often asked, what's a good patient to start with for canaloplasty? And certainly, most of us surgeons, when we're starting a new procedure, want to be very, very careful in terms of first doing no harm. With canaloplasty, fortunately, there's a very low risk that you're going to do any harm. That's difficult for most of us to accept simply because we think of incisionally based glaucoma surgery as being quite risky. But without the bleb, much of that risk really is removed. So your ideal patients are actually going to be your patients with cataracts who are considering cataract surgery, who also happen to be on multiple medications. Now, we've heard a lot about cataract surgery alone reducing pressure. And although that does seem to be true, if your patients are on 2 or more drops and considering cataract surgery is not going to get them off all of their drops. So patients who are motivated or interested in potentially being free of drops are your ideal canaloplasty candidates if they also have a cataract that you are planning on removing. So that would certainly be one group of patients that I would recommend that you consider as your early canaloplasty patients. Other patients include those who have significant ocular surface disease, who are more than just annoyed by the problems of dry eye. These patients, if they're also on 2 or 3 glaucoma medications, are usually quite interested in having the option of being free from drops so that they can better enjoy things like extended reading, computer use, and just generally the quality of their vision. So I think between those 2 groups of patients, you'd be surprised by just how many patients you have in your practice already who are excellent candidates for canaloplasty. Another concern that I hear quite frequently is this steep learning curve that's been spoken about. And I'm not going to suggest that there's not a steep learning curve or that it's easy to pick up canaloplasty. This is a different procedure. And just as when you were a resident, it was difficult for most of us to pick up all of the steps and the complexities and the finesse of phacoemulsification, the same is true with canaloplasty. This is a different surgery requiring different techniques, steps, and skills than you may be used to. That being said, anyone who's learned how to perform phacoemulsification can pick up the steps for canaloplasty. If there's one thing that I would encourage strongly in order to get you past the learning curve, it's to schedule as many cases as you can in as short an interval as you can. Ideally scheduling 3 to 4 patients on your first day and then getting another 3 to 4 patients within weeks is going to help you get through this learning curve much faster, because if you wait too long, you're essentially restarting your learning curve. One concern that almost all surgeons have about canaloplasty is the time that it takes to perform canaloplasty. Now, rather than give you an exact time of what you can expect, I would simply suggest that if you're one of the faster surgeons out there with phacoemulsification, you'll probably be pretty fast with canaloplasty once you've learned all of the steps and become comfortable with it. If, on the other hand, you're one of the slower surgeons, such as myself, and just kind of enjoys the surgery like a good glass of wine, then you'll really enjoy these steps, and the concern about time is not really something that is going to limit you. One of the really nice things about canaloplasty from a surgeon's perspective is the anticipated post-operative care. In general, it's quite close to cataract surgery. Generally, I'll see my patients one day, usually a few days to a week after that, a few weeks to a month after that, and then 2 to 3 months after that. So in my practice, that's very close to cataract surgery. Compared to what you might anticipate, as if you can anticipate anything about the post-operative care of trabeculectomy or a tube, is that it just involves far less chair time, is far more predictable, and even in those unpredictable visits, they tend not to be time sinks. In general, when you compare the postoperative care of canaloplasty to a bleb-related surgery, you're simply just not going to have the same number of postoperative visits, nor are you going to have to deal with the same complexity. Often, the visits are short and anticipated. You simply don't have to worry about laser suture lysis, reforming anterior chambers, or the many other things that can actually mess up your schedule and put you behind during postoperative days. Some of you, like I had thought in my past, may be wondering, do I really need to learn a new glaucoma procedure? After all, I don't really think I have that many glaucoma patients in my practice that are in need of glaucoma surgery. Well, that's certainly what I thought before I started canaloplasty. I was sending out perhaps half a dozen patients a year, certainly not enough to provide me a basis of learning canaloplasty. But one of the things I discovered is that this procedure is one that patients, once they've learned about it, actually request. So my glaucoma surgery practice grew from a half a dozen patients, sending them out to somebody else, to 60 patients my first year of doing surgery, strictly from within my own practice and patients requesting to have the surgery. Now, that sounds a little unbelievable, and I certainly wouldn't have believed it myself had somebody told me that. But one of the key things with canaloplasty is this really is a patient-focused surgery. Patients really don't like taking their drops. And if you ask them about this, you'll find out for yourself. They're expensive, they're irritating, they have side effects. When patients find out that there is a relatively low-risk surgery that has a real chance of getting them off their drops, that's something that's of great interest to them. And once you're comfortable with canaloplasty and see the benefits to your patients, you'll find that your comfort level of offering a surgical treatment to take patients off drops is one that will be both satisfying for you as well as for your patients.